Hello everyone, this is Dr. Suraj here. Today we'll be talking about immunodeficiency disorders. Now, immunodeficiency disorders, we have primary immunodeficiency disorder, secondary immunodeficiency disorder, and this primary immunodeficiency disorder can be innate or adaptive. And the secondary immunodeficiency disorder like secondary to HIV, cancer, chemotherapy, but the most common cause of secondary immune deficiency disorder is malnutrition. Okay, what we will be discussing here basically that the adaptive immune disorder may be due to defect in the lymphocyte maturation, okay, like B lymphocyte maturations, T lymphocyte maturations, okay, or maybe because of defect in the lymphocyte activations, or because of B and T combined defect, or phagocyte dysfunctions. Okay, so we'll be studying everything. So first thing that we are going to discuss here is the B cell disorders, which are basically causing the immunodeficiency. Now if you see the B cells, we have the pro B cells here, and these pro B cells are getting converted, or they are matured. For their maturation, one gene is needed, that is what is known as BTK gene, that is Bruton tyrosine kinase gene. And once these B cells are matured, this matured B cells will be then converted to plasma cell. This matured B cells will be converted to plasma cells, and this required BAFF gene. This requires BAFF gene. Okay, and once the plasma cell is produced, this plasma cell is gonna produce first antibody, that is IgM kind of thing. So first antibody that is produced, the first class of antibody, that is IgM, and this IgM will go for class switching. That means first is the IgM class is produced, and then it will go for class switching, and once it goes for class switching, from here the IgA, IgE, IgD, IgG, other antibodies will be produced. And for this class switching, what is needed is the interaction between B and T cell. So B and T cell may interaction is what is needed. Okay, and for that the B cell ka CD40 ligand and T cell ka CD40 what interacts with each other, and they cause class switching. We'll be talking about each of them. So CD40 ligand interaction is needed for the class switching. Now why this is important to understand, we'll be talking about that. Like here, in case of Bruton's agammaglobulinemia, this is a condition which is X-linked recessive condition. First thing, it is X-linked recessive condition, and that's why it is more common in boys. That's why it is more common in boys. Understanding? Here what happens, this BTK, that is Bruton tyrosine kinase, is deficient, and because of that the B cells are not getting matured. So in the periphery you will be having absent B cells, and as the B cells are not getting matured, so immunoglobulins of all the classes will be absent. It's not only the IgM, so matlab IgA, IgE, they are deficient obviously, but obviously the IgM se they are deriving na. So IgM, the first class of antibody, they are also going to be decreased here. There also the level of the antibodies are low, and as they are not maturing, the B cells are not maturing, so they are not going to form any kind of tonsils or any kind of lymph nodes. The germinal centers will be atrophied or absent rather. Okay, that's why if you give live vaccines to them, that will cause severe infections, because the live vaccines, when we give the live vaccines the live vaccine will stimulate the antibody production in our body, but this pathway is not going to happen because the B cell cannot mature there. No, so live vaccines are not contraindicated. Okay, next thing that what you have to remember here is that BTK, see here, BTK gene is defective and there is no B cell maturation, X-linked recessive, I told you, and there is, because of B cell defect, there is recurrent bacterial infection. Infection with enterovirus is what is very important. So enteroviral infection is very, very important, but that is seen after 6 months, because till 6 months the baby is breastfed, and that by that the baby is receiving the IgG from the mother, because IgG can cross the placenta. So typically after 6 months the baby will be getting these enteroviral infections. Okay, next is selective IgA deficiency, where basically the IgA class is deficient, and this is what is most common primary immune deficiency disorder. Most common primary immune deficiency disorder. This patient IgA is present in the secretory surface, mucosa. So it is present in the mucosa. Now this is not present, IgA is deficient there, so the mucosa like oral mucosa, the GIT mucosa, this will lose their immune functions. So because of decreased IgA, there will be increased susceptibility to giardiasis. Okay, you can remember GIT mucosa, giardiasis infections will be increased. There will be risk of giardiasis infection. Generally the patients are asymptomatic, but it can cause airway, as I told you, oral and respiratory mucosa, GIT infections, and increased risk of anaphylaxis to the blood products. Okay, it can cause false negative celiac disease test and false positive pregnancy test also. Now here please do remember another variety of B cell disorder, which is combined variable immunodeficiency disorder. Here the B cells are maturating, but it cannot differentiate, understanding, and here the defect is in the BAFF gene. Because of this defect, guys, what is happening, this step is not happening. So mature B cell though abundant hai, so you will be seeing that in the peripheral circulation the B cells are high, but the plasma cells are not getting formed because this pathway is getting involved. Okay, so B cell differentiation is lost, and that is what is your common variable immunodeficiency. So here this patient will be typically present after, at adolescent. Okay, that is usually diagnosed after puberty, and this patient will be having increased risk of lymphoma and autoimmune infections. Why lymphoma? See, the mature B cells are there, so they will be accumulated in the lymph nodes, in the thymus. Sorry, they will be accumulated in the lymph nodes, and they will cause germinal hyperplasia, so can cause lymphoma also. But this is typically absent in case of Bruton's, because the matured B cells are absent there. So just try to correlate. Okay, so the main important point is adolescent mein hoga. After adolescent, there is increased risk of sinopulmonary infections, because plasma cells are decreased, so decreased antibody production, the sinopulmonary infections will be increased. Okay, and there will be decreased plasma cell as well as decreased immunoglobulins, but B cells will be high. Okay, that is important. So if you see absent B cells in the peripheral circulation with absent IgG of all classes, it is Bruton's, and as it is also associated with enteroviral infection. If you see that only IgA class is deficient with others are normal and associated with giardiasis, okay, that is what is your selective IgA deficiency. If you see the plasma cells are low along with other immunoglobulins, but B cell is normal, or it is rather increased, that is what is your common variable immune deficiency disorders. Let's talk about the T cell disorders, T cell mediated immune deficiency disorder. Now this is very important slide. The T cell mediated disorder, the first thing that we are going to learn here is what is known as DiGeorge syndrome. So thymic aplasia, which is seen in DiGeorge syndrome. DiGeorge syndrome is also known as velocardioinsufficiency syndrome, velocardiofacial insufficiency syndrome, and can be remembered by acronym, can be remembered by this mnemonic CATCH22, CATCH22. Okay, so here you see velocardiofacial syndrome means, velo means palate, so there will be cleft palate. Okay, cardio means the patient will be having conotruncal defect, the most common one is your tetralogy of Fallot. Tetralogy of Fallot is the most common cardiac abnormalities. Okay, the facial means there will be asymmetrical face. Why? Because of the cleft palate and cleft lip, there may be asymmetrical facial conditions will be there. Okay, T and H, you have to understand this thing. Why? Because in Dijord syndrome, this 22 denotes that micro deletion is happening at 22q11. That means in the 22q chromosome, in the 11th position, there is micro deletion, because there is a gene that is what is known as BT, that is TBX gene, TBX1. This gene is responsible for the development of the third and fourth pouch, the pharyngeal pouch. Do you know from third and fourth pharyngeal pouch what are the structures arising? Third and fourth pharyngeal pouch. So third is giving thymus and inferior parathyroid gland, and fourth is giving superior parathyroid gland. So ultimately, if you are saying there is defective TBX1 because of the microdeletion of 22q11, I can say that neither the thymus is developing nor any part of the parathyroid is developing. So the patient is having thymic aplasia that we are discussing, and the patient is having parathyroid aplasia also. So if parathyroid aplasia is there, there will be no PTH hormone. There will be no PTH, and PTH is regulating the calcium level in blood. So there will be no calcium, there will be decreased calcium or hypocalcemia, and that are the typical findings. See, decreased parathyroid hormone, decreased calcium, that can lead to tetany. Okay, so this catch-22 is the mnemonic from which you can derive what is Dijord syndrome or velocardiofacial syndrome. See here, pharyngeal pouches are absent, third and fourth, they are absent, leading to thymic and parathyroid aplasia. Okay, catch-22, there is cardiac defect, I told you, most common is TOF, then abnormal facies, I told you, thymic aplasia, I told you, and because the thymic aplasia is there, thymus is the area where T cells are getting maturated. That is not happening because of thymic aplasia, so T cells will be decreased. And you know, when you take chest x-ray in babies, you will see that in the upper mediastinum, there is a butterfly shaped shadow, and that shadow denotes what? Thymus gland. That is typically absent in us. So that shadow will be absent in case of children who are having this velocardiofacial insufficient, this Dijord syndrome. Okay, there is hypocalcemia and cleft palate that I mentioned. Please remember, this is what is 22q micro deletion. There is no full deletion of that chromosome. Next is what you have to remember is interleukin 12 receptor deficiency. It is because of the T helper 1 response decreased. It is because the T helper 1 response is getting decreased, and this interleukin 12 is responsible for interferon gamma production, and this interferon gamma is basically needed for granuloma. Now, interferon gamma is responsible for the granuloma. So please remember, this is the most common Mendelian disease which is associated with mycobacterial infection. So 12 is associated with TB. You can remember in that way. 12 is associated with TB. There will be disseminated mycobacterial and fungal infections, and if you even give BCG, that can, you know, after administration there may be disseminated mycobacterium TB following a BCG vaccination. That is very, very important. So this is what is your interleukin 12 deficiency. So you will be getting decreased interferon gamma in blood. Next is what is known as Job syndrome or hyper IgE syndrome. It's also a T cell deficiency disorder, T cell disorder which causes immune deficiency. So you can remember it like it's an autosomal dominant variety. So basically learn ABCDEF, okay, to get a job stat. There is STAT3 mutation, okay, and this STAT3 STAT3 is required for the recruitment of the neutrophil. Please understand it. There is no recruitment of the neutrophils to the site of infection, and that can lead to increased infections and formation of cold abscesses. Okay, cold abscesses, and this patient will have retained baby teeth, and there will be increased fracture because of trivial trauma also. The patient will be having increased EEEE, that is IgE, and eosinophils, because the neutrophils cannot go, so eosinophil is going, and that is causing this non-inflamed cold abscess. Typically this is what they will be saying, baby teeth, and there is fractures due to trivial trauma. This is what is job syndrome. You can remember job, you need a job which is a stat, you require a job, and for getting a job you need ABCDEF. To learn ABCDEF, you have to learn. Okay, so you have to learn ABCDEF, that is cold abscess, baby teeth. There will be cold species, dermatologic problems will be associated, but what is important I marked. Now another is chronic mucocutaneous candidiasis, that is also important. Here what you have to remember is basically there is T cell dysfunction, and that is why what happens, though there is presence of the candida antigens, but there is absent of T cell proliferation in response to that particular candidal antigens. Okay, so because of that there will be persistence of non-invasive candida albicans infections in the skin and mucous membrane. Understanding? And this is because of classically the classic form of this disease is because of defects in AIRE, that is autoimmune regulator defect. Okay, that is what you have to be remembering. So this is particular to the candida. Now we are going to discuss both combined defects, that is B and T cell disorder. B and T cell disorder, guys, both combined defect. That means here what happens, first thing is severe combined immunodeficiency. Here both B cell, T cell, the natural killer cells, those are actually defective. So please remember the most common variety is X-linked recessive, but it can be autosomal recessive one variety where there is adenosine deaminase deficiency. That is very important. Okay, so what is the most common? So this is because of the adenosine deaminase deficiency. What is the most common variant? That is X-linked recessive, and that is because of, why? That is because of the gamma chain of the interleukin receptors. There is a mutation. So there is a mutation in common gamma chain of the interleukins. So interleukin 2 receptor gamma chain mutation is there. That is what is X-linked recessive. So that is one mode. That is another mode. Another is RAG3 mutation that can lead to VDG recombination defect. That is not needed. What you have to remember is the X-linked recessive variety is most common, and the ADA deficiency is associated with autosomal recessive variety. Okay, typical history they will give is infections to any organisms like viral, bacterial, okay, fungal, protozoal, anything. Okay, in T cell disorder, that is most that infections are mostly towards fungal or viral. Here there will be recurrent viral, bacterial, fungal or protozoal, any kind of reactions will be, infections will be there, and that will be recurrent. The history will be there, that is failure to thrive, chronic diarrhea and thrush. Now you see that the patient is not having there is defect in the T and B cells. So the patient is having decreased T cell receptor excision circles. That is what is TREX. You have to remember this one. Decreased T cell receptor excision circles, and the patient will also be having absent thymic shadow like Digeorges, as also absent germinal centers. So if you do lymph node biopsy and you put the pan T cell marker, that is CD3, you will see that the T cells are less. Okay, this is what is combined severe combined immune deficiency. It's an X-linked, तो मेल में ज़्यादा दिखेगा, and this patient is prone to get any kind of infections, and even the fungal infections are also there. You will be getting diaper rashes, the oral thrush, the diarrhea, etc. That is important. Next, coming to ataxia telangiectasia. Ataxia telangiectasia, is what is the defect in the ATM gene. Now what is this ATM gene doing? This ATM gene is actually detecting the DNA damage. Okay, and if there is any mutation, it will halt the progression of the cell cycle. But due to defect in that ATM gene, ataxia telangiectasia, okay, that is ATM gene is there. If that is defective, there is failure to halt the progression even if there is DNA damage, and that can lead to accumulation of the mutation. So please remember, the patient will be having the triad of ataxia because of the cerebellar involvement. So you can see the cerebellar atrophy. Okay, and you will be getting telangiectatic spots in the face. So that is what is angioma, spider angiomas will be there, and typically the patient will be having IgA deficiency. Okay, this will increase the risk of lymphoma and leukemia, and there is an increased sensitivity to radiation. That's why in this patient you have to limit the X-ray exposure. Okay, the patient will be having lymphopenia also. So please remember the characteristic feature: patient having ataxia, spider angiomas, decreased IgA. Okay, that is what is ataxia telangiectasia. One condition I told you in T cell, that is hyper IgO or job syndrome. You remember ABCD, learn ABCD to get a job stack. That is, here is hyper IgM syndrome. That means the IgM level is increased here. Understanding, the IgM level is increased here. So please remember, this is very important. Why? Because I told you previously, for IgM to be produced, this plasma cell is converted to IgM. Now for other classes of Ig immunoglobulins to produce, you need this class switching, and this class switching is happening because of the B cell. B cell is producing the CD40. B cell has the CD40, and T cell is having the ligand for this CD40. Okay, T cell have the ligand for the CD40. So CD40 ligand. Once there is interaction between these two, then what happens? This IgM production, there will be class switching, and there will be other antibodies, other classes of antibodies being produced. Other classes of antibodies will be produced. Now, that is not happening, because most commonly what is happening in the T cell, the T helper cells are having defective ligand for CD40. That is the most common one. The second most common one is B cell में CD40 defective. Okay, the most common one is the T cell में ligand defective, and that causes defective class switching. So IgM ही रह जाएगा. So there will be increased IgM, and other IgG, IgA, IgE will be very low. Okay, and there will be failure to make the germinal centers also. Now what you have to remember from here, that these patients are severely having a severe risk for pyogenic infections in the early life, and they have opportunistic infections with the pneumocystis and cryptosporidium and CMV. Why that is happening? Because see, the IgM is increased, and this can lead to autoimmune thrombocytopenia, autoimmune hemolytic anemia, autoimmune neutropenia, etc. But because the other classes of antibodies are absent, they increases the risk of sinopulmonary infections. So the patients will be very much having the risk for getting the opportunistic infections. That is what is hyper IgM syndrome. Next is Wiskott-Aldrich syndrome. So here the defective gene is WASP gene. This WASP gene is needed to mature the T cell cytoskeleton. Okay, so if the cytoskeleton are not matured properly, so the T cells are not gonna develop properly. So here this is required to stabilize the T cells. So this is leukocytes and platelets which are unable to recognize actin cytoskeleton, and there is defective antigen presentation. As I told you, just remember, there is defective cytoskeleton development in the T cells as well as in the other leukocytes, and that causes defective disorders that can be remembered as thrombocytopenia, eczema, and recurrent infection. So you can remember that mnemonic water, or also you can remember it as water. Okay, here water is Wiskott-Aldrich syndrome. There is thrombocytopenia because the leukocytes are because the platelets are not having those cytoskeleton. Here can be eczema and recurrent pyogenic infections because of decreased antibody productions. But please do remember here that these patients are having this IgM level that is very low. Wiskott-Aldrich, this patient will be IgM will be low. Other antibodies might get increased or normal, but this IgM will be very low. Okay, so you can remember in hyper IgM the IgM is increased, so M ka ulta W, that is Wiskott-Aldrich, so isme IgM will be decreased. Okay, that is what you have to remember. Now last so here another important thing I want to mention that was asked, that severe combined immune deficiency is X-linked recessive, the most common one. Ataxia telangiectasia is autosomal recessive. Okay, but hyper IgM is again X-linked recessive. Wiskott-Aldrich is also X-linked recessive. Please remember these three. Bruton's agammaglobulinemia was also X-linked recessive, I told you. Okay, so this is important. Now coming to the phagocyte dysfunctions, and this is the last slide. Here what you have to remember is, first thing is leukocyte adhesion defect. First is leukocyte adhesion defect. The adhesion defect is because of the integrins defect. The integrins are defective. Integrins are CD18. Because of the defect in this, the neutrophils cannot migrate, or there is no chemotaxis happening, there is no migration happening. So the neutrophils, basically there is no diapedosis. So what happens, the neutrophils are residing inside the blood vessels, they are not reaching to the site of infections. So typically this patient will be having neutrophilia. This patient will be having neutrophilia. So neutrophils count is increased in the peripheral blood, but because there is absence neutrophil in the sites of the inflammation or infections, this patient will be having recurrent skin and mucosal infections with the bacteria. Okay, that is important. But still, because of recurrent infection is there, but still there will be lack of wound healing, because wound healing ke liye neutrophil is very much important. The typical history they will give there is late separation of the umbilical cord. So you can remember it like leukocyte adhesion defect, that is late separation of the umbilical cord. A for you can remember absent pus, because pus is formed by the neutrophil. And deficiency, the D is dysfunctional neutrophil. So there is again and again infections with the bacteria. Okay, it is autosomal recessive condition. Next is Shediac-Higashi syndrome. So you can remember it as Shediac-Higashi syndrome. So there is high granules inside the phagocytes. Now what happens, that phagocytes have this high number of toxic granules inside, and then it will combine with the lysosome and then it is going to form the phagolysosome, and that will be destroyed by the lysosomal enzymes. But that is not happening because of the deficiency of lysosomal trafficking. Because of deficiency of the lysosomal trafficking regulator gene, this is not going to happen. So these phagocytes are actually there with their this granules inside, and this is not going to processed inside the lysosome. So here this patient will be presented to you with large granules will be there, and the patient will be having progressive neurodegenerations, and albinism. So albinism will be a very important findings here. Also pyogenic infections and neuropathy. Here the platelets will also be involved, so there will be mild coagulation defect. So please do remember, Shadiac Higashi high granules are there because of the least gene mutation, that is a lysosomal trafficking regulated gene mutation. It is also a autosomal recessive disorder. Okay. Next is chronic granulomatous disease. The chronic granulomatous disease, you know, this is what is known as chronic granulomatous disease. So C4, you can remember, there is increased risk with catalase positive organism like Staphylococcus aureus, like Nocardia, Candida, Serratia, etc. C4, you can also remember, that is chronic granulomatous disease, CGD. Okay, C4, you can also remember the color tests, like what we can do. Okay, the tests, color test. One is what is known as dihydrorhodamine test. This is a flow cytometric test where there will be decreased green color. But what was done previously is nitroblue tetrazolium test, and where there will be, you know, fail to turn the reaction to blue color. That is what will give a CGD positive. So basically chronic granulomatous disease, and that is because of the defect in the NADPH oxidase. What is happening here? See, whenever there is infections, we need the respiratory burst to happen. This respiratory burst means this will going to produce the superoxides, okay, that will tackle the oxygen free radical, and that will prevent the free radical damage. But because of the defect in the NADPH oxidase, what is happening? There is decreased this reactive oxygen species formations, and there is decreased respiratory burst also, and that cause this respiratory bursts are not happening in neutrophils. These are needed to tackle the infections. Okay, and there is increased susceptibility to catalase positive organisms, and there will be recurrent infections and granulomas. Okay, so these are all you have to be remembering. So revising everything, just be patient. So if they give like albinism is there, so if they give there is albinism and the patient is having giant granules inside the macrophages kind of images, so it's a Shadiac-Higashi syndrome, the patient will be having recurrent pyogenic infections. Supposing they have given that the patient is having neutrophilia and there is very high risk of infection. Now neutrophilia is there and high risk of infections are there, so generally that is what is leukocyte addition defect. Here you have to be noticing one condition, that is delayed separation of the umbilical cord and cold pus. Okay, next is your B and T cell defect. Both, if they have this ataxia and angiomas, then it is ataxia telangiectasia. There will be cerebellar atrophy and the defect is in the ATM gene. If they are giving like IgM is increased and others are decreased, and the patient is having risk for severe pyogenic infections, okay, and other opportunistic infections, it is hyper IgM syndrome. Okay, if they have given thrombocytopenia, recurrent infection, eczema, and the IgM is decreased, then it is Wiskott-Aldrich syndrome. Okay, that is Wiskott-Aldrich syndrome. There is WASP gene defect. Now if they give that all the antibodies are decreased, the B cells are also absent, okay, and the plasma cells are also absent, that is what is Bruton's gamma globulinemia. But B cells are present, plasma cells are absent, immunoglobulins are absent, then it is combined, that is common variable immunodeficiency. In combined immunodeficiency, what is the case here? There will be in X-linked recessive variety is most common because the gamma chain is mutated. Okay, it's not the gamma chain of antibody, it's the common gamma chain of the interleukin receptors. Okay, so this is what you have to be remembering. Don't forget to remember the Bruton's gamma globulinemia, Okay, then this one IgA with giardiasis. Okay, then here Di-George's syndrome. Okay, here Job syndrome, here SCID, hyper IgM, ataxia telangiectasia. Okay, Wiskott Aldrich chota chota, and here leukocyte adhesion defect and Shediaki-Gassi syndrome and CGD. Everything you have to remember. You can forget the others. They're like selective IgA, but still it's you can remember it by Giardia infection and other secretory surface, the mucosal surface involvement. Thank you.